We have Dr. Natasha, and here again, a deep diver. So Natasha is there as Chief of Cornea and Refractive Department at Natasha Eye Care Research Center in Pune. So over to you, Natasha, and your story.
Thank you so much for this humbling opportunity. I think I'm a personification of the discussion that happened a second back about residents and fellows aiming for Rangachari, and I think I'm a living example of that. With this, I would like to share my humble journey. Are my slides visible?
Yes. Full screen, please.
Yes. In the process of in the next 7 minutes, I'm going to try and justify and give justice to all the blood and sweat that has gone of 7 years of all the people, every single individual who has been involved in this journey. To understand what Colonel Rangacharis, we were as a resident and as a fellow, we used to always ask as to what is the secret ingredient to win a Rangachari. And what was very profound in this was that if you look at all the previous recipients, they're coming from either big institutes or group practice. But what was very encouraging was there were winners who are solo practitioners or are coming from private practice with simple ingenious ideas, and lesser mortals like me who have just finished fellowship and were competing for this. The most profound and the most common thing in all these papers which I've read individually is that every single paper is bringing about disruptive change in science and technology, which means they were highly innovative, no matter how simple they were. And they had an intention of clinical translation and bringing about a better human health and well-being and better productivity for our fraternity. One such disruptive change was brought about by my mentor, and I can't thank Dr. Partha for bringing up this topic today on Guru Purnima. Where my mentor actually challenged the entire definition, and that was quite inspiring, that we have believed it for 150 years that it's non-inflammatory, and he asked, is it really true and how do you know? And he proved it that there is inflammation in keratoconus, and this definition is accepted worldwide. And this from this point onwards the journey continued. But what was very important was that understanding the mindset of a Colonel Rangachari winner was that once I sent him a message and I told him, sir, we should celebrate. His response to that was, let's start brainstorming for future projects. I'm just boarding my flight. And that just explained that, this journey is not something that you can sit back and celebrate it. It involves a lot of thinking from day one itself. So in this process or in this journey, we started asking as to the basic question. Now, ectasia is happening at a molecular level. So why are we not looking at keratoconus from a molecular level? Why are we primarily looking at only the clinical outcomes? So there was a significant knowledge gap. So we were feeling that probably we are not getting the desired outcomes because we don't know what is happening at a cellular level. This was the basic intention of the entire work. And this was a part of my PhD work or the thesis as we were discussing. So what we used to start doing is at the beginning of the clinics, we started collecting biosamples of all the patients who were a part of it. By the end of it, by the end of the day, we used to sit and we have collected almost 6,000 patient demographics and put into Excel sheets and days and nights together, figured out which keratoconus is stable and which is not. And in this entire process, what we found was that there were stronger validations of what molecular research we were doing. That there is inflammation and there is lack of endogenous cross-linking in keratoconus. This was the only molecular signature we were getting. Now, after this, I kept asking my mentor as to I'm presenting these papers, even in, I could not even qualify for, my abstracts did not even get accepted at various national and international level. So I just kept asking sir as to, I can't see a way through. I mean, how will I finish my entire PhD if I can't even get a paper through? And he just kept telling me that, at least can you see the next step? And I was like, I'm just a clinician and probably the best I can do is operate and then see patients and make sure that they are doing okay. And he said, okay, let's focus on that and the answer will come to you. So we went back to clinics. We also, in that process, in that humility, we just started working on the clinical outcomes. But my PhD was entirely on the etiopathogenesis, and it was a mol bio PhD. So I just kept telling sir, so where is that disruptive change that is happening? And that's the time that my mentor said, okay, you just sit and observe certain things in the clinic and probably you'll find answers there. And this is what we were doing. One of the evening, we were looking at different grades of keratoconus. And I was just asking, sir, so do you notice that in every topography, no matter what grade the keratoconus is, the disease is primarily localized. Does that mean that this may have a different molecular signature and that's why we are not picking up a different trend? And that is when he said that probably, and if you feel that that is a question, be brave enough to ask for help. And that is the time we asked for help from the brilliant scientists at Grow Lab. And we started questioning them that what could it be that there's a different molecular signature? The first thing that I asked them is that my intention at that time was, sir, I need a paper for my PhD thesis. Do you think this has been done before and is it novel and do you think it's going to go through? So everybody at that time told me just work and probably something will come out of it. So what we did was in the clinic, we collected the epithelium from the center and periphery of the same eye of the same patient in keratoconic eyes. And these were being collected in a biorepository and being saved. After which we made a clinical study out of it and we went back to the biorepository and looked at the molecular signature of some patients. And quite honestly, at that point of time, I was very grateful for all the cross-linkings that I have done, sitting for one hour, doing the dressing protocol and collecting the epithelium, because at that point, I was very grateful to at least have a glass, forget of glass being full or empty. And that's where this proceeded. We started doing studies. Yes, we started doing the molecular biology studies. We did quantitative PCR for different grades of keratoconus in the cone and the periphery, had very good controls in PRK, did Western blot analysis, did flow cytometry to really absolutely understand what is happening at a molecular level. And this is what translated into the Colonel Rangachari Award that I received in 2017. And this was the first slide at that time. But in this disruptive change, what I also learned was that there has to be a process. You cannot just come up in an unstructured manner and say that this is my paper and I'm going to win it. There has to be a concept. There has to be an experiment which has to be proven. It has to be applicable to the patients, and there should be a therapeutic or a clinical translation to it. The concept of this paper was that if there is inflammation, that what if the inflammation is not getting wiped off? What if there is increased apoptosis and it's not getting cleared? And that is what this paper was. We studied that there is a process of autophagy which had never been studied in keratoconus or any other ocular disease before. So what we found was that if the misfolded proteins don't get cleaned up, that means the housekeeping mechanism or the cleaning mechanism is not working. All this is obviously getting collected at the surface, and that is what is causing inflammation probably. And we found that this fortunately had won a Nobel Prize just a year before. So we looked at it from the keratoconus perspective. We realized that oxidative stress truly is one of the factors as a positive factor for keratoconus. And we wanted to see if this really holds true. So what we essentially did was, we cannot obviously go back to a keratoconus patient who did not have keratoconus and come back when they developed keratoconus. So we could not go retrospectively and see them. What we did was prospectively in normal cells created oxidative stress. So in that process, we could prove a concept. And what we found was that if we induce hyperoxia, if we induce oxidative stress, there is increased autophagosomes. That means the cleaning mechanism gets defective and the autophagy gets defective. Now we wanted to see if this really holds true in patients in KC eyes as well, or this is just something that we are seeing in the lab. So what we figured was that in patients of keratoconus, in the cone, there was defective autophagy, but the area which was not ectatic, that area was as normal as a PRK patient, as a patient who was undergoing refractive surgery. So what we essentially found was that truly there is defective autophagy, and this could be one of the mechanisms which could be possibly a pathophysiological mechanism for progression of keratoconus. Now, the important aspect was we know that there is a problem, we had to find a solution. So after hours and hours of reading, we figured that there is a way of a commercially available preparation, which was chloroquine at that point of time, that could initiate autophagy. So what we essentially did was we again went back to the lab and saw if this was truly possible or not. So we induced hyperoxia again. We saw that there's defective autophagy, there was more autophagosomes. We treated it with chloroquine and we figured that it is responding to chloroquine. So we were very, very excited that, there is optimal autophagy just by eye drops. Further, we decided to look as to what are the other targets. And we came across this disaccharide, which is currently primarily being used as a lubricant, which was trehalose. And we started making this drop in India. So I was so proud that this is something coming from my country that we have made. And this eye drop was commercially available within a very 6 to 8 months of time, only because it had very good science backing it. And most importantly, it was a very, very simple innovation. What was further important is that this paper showed that this was the first evidence of altered autophagy in keratoconus, and we could quantify it. Most importantly, we figured out there's a novel drug and we created it in our lab, and it is being currently used in every clinic today. This was what translated into this. I still get goosebumps when I see this, into a Colonel RANGACHARI award. But most importantly, this was not the end. This is still the beginning. There is so much work that is still happening. So we started thinking at that point, what if we could have customized treatments? Instead of just blaming, probably there's inflammation, there's oxidative stress, there is autophagy, there is not autophagy. Why not look for it? So predominantly, we started collecting tears and started seeing which of these patients have got which pathway deregulated. And what are we proposing by this is that there could be probably 3 to 4 years down the line, pharmacological cross-linking. That means you don't need riboflavin, you don't need UV light, you just need eye drops for stopping the progression of keratoconus. And how does it change my practice today? There are 3 or 4 commercially available eye drops which are currently being used with nil to minimal side effects. And as I've always been taught by my mentor, that no man is an island. One person cannot bring about such a disruptive change, and you need an entire team. And these are brilliant clinicians, brilliant human beings, and very humble, very good mentors who have made lesser mortals like me more able and better human being over a period of time. And I would like to conclude by just saying this much, that there was a lot of resistance when I was going for my free paper session. It was just 1 week after getting married, and there were a lot of fingers being pointed as to why is she going just 1 week after into the marriage, going alone to some conference, and this is not the time for all of this. This is a time for a personal thing. I think if somebody as small as me can prioritize it, no matter how small you are, you can make a huge difference just if you have the right intention in mind. Thank you very much.
Thank you very much, Natasha. So much of inspiration from all of us. And what you really have done, you have not only shown the way, but you have walked it and you have inspired. So over to Namrata for your comments, Namrata.
For me, it is a pleasure to be commenting on Natasha because I've known her for many years now.
Yeah.
And more importantly, because she's worked on keratoconus, because I also got Rangachari on keratoconus. More importantly, because mine was epikeratoplasty versus penetrating keratoplasty in keratoconus, which was a surgical treatment. And she has, shown how you no longer probably would need surgery for keratoconus, and everything is going to be, treated by collagen cross-linking, or for that matter, even drops. You presented it beautifully, Natasha. And there was so much of passion involved, so much of commitment that could be seen. I think excellent work, not only for our country, but internationally. All of these have been really acclaimed at various national and international platforms. And may you continue to walk all the miles, and you are not too small. Your work is very big. So keep it up.
Thank you so much, ma'am. Thank you.
Thank you very much, Namrata. Sonu, are you there? If not, Chitra, you do a lot of work on refractive surgery. Would you like to comment?
Actually, I wasn't so sure that I'd be so dumbfounded and so impressed by this session. And kudos to Partha and the entire scientific team to have come up with this. And what I learned, besides being innovators, the kind of passion, the kind of perseverance, the kind of commitment, it was truly amazing. I mean, there's no point in repeating what Namrata said, but every single sentence which Natasha, you spoke, I actually could repeat it back. So that's kind of impact which you made about the subject, about the passion. And I think this will definitely percolate into the attendees, the young people who are watching. If person at my age could be so motivated, I felt that I needed to go back 20, 30 years to have done something more in my life. So kudos to you and kudos to one and all of you for a wonderful session today.
Thank you very much. Thank you, Chitra.